This is case of the day, and we're on 110th case, another week and another 4 cases, Monday to Thursday, and today is the 110th case, a distal clavicular osteolysis in a bench presser. This 24-year-old came with pain in the right shoulder. He bench presses heavy weights regularly, and this was the MR. That's the AC joint and coronal. That's the T2 fat sat. That's the T1, and that's the proton density axial. And we can see the marrow edema in the distal end of the clavicle, the capsular thickening fluid. There's a subchondral defect, and there's a little bit of marrow edema in the acromion. So this is very characteristic of distal clavicular osteolysis, and in this case it is not a result of direct trauma, so we can call it atraumatic. So DCO can be traumatic or atraumatic. It is associated with bench pressing intensity. So this was a very interesting paper about 9 years ago, which looked at the extent of bench pressing and found that those who had a significant volume, compared had or at least those with DCO and bench pressing had a significant increased amount of bench pressing that they were doing. So when atraumatic, it's usually due to repetitive stress, and therefore it's called the weightlifter's shoulder. But bench pressing is perhaps the most common form of weightlifting that perhaps causes DCO. But, and while it is supposed to be commoner in young men because young men are more frequent visitors to the gym, it can occur in 24% of women. That's because more and more women are now doing the same thing. And it may occur in those under the age of 19 or 20. And in these people, while again it may be due to lifting weights, it can also be associated with repetitive overhead sports activities like volleyball, etc. You can grade it as well. So these are the 3 grades that this paper came up with, and now that this seems to be the standard, and it's based upon the extent of marrow edema. So if it's partial, it's grade 1. It involves the entire distal clavicle, it's grade 2. And if we have associated findings like in our patient with periosteal reaction, capsular thickening fluid, then it's grade 3. So you have 3 grades. And you can have involvement of the acromion, which has not earlier been described, and this particular paper showed that about a third of patients had acromion involvement as well. So our patient has acromion involvement. He has grade 3 disease, and that's the classification if at all you wanted to do that. And it's quite a severe form of DCO that this patient has. Why does DCO occur? One theory is that this is the result of a subchondral fracture, and this paper found 86% of patients to have some form of a subchondral fracture. This is another 42-year-old lifting weights, has a grade 2 DCO. The marrow edema goes all the way across, and there is this subtle subchondral line paralleling the articular surface, which appears to represent a fracture. That will be this black line, and this is the fluid in the joint. You can see that even on the T2 here, where you see this black line. So that's the subchondral fracture. And this is a 28-year-old woman who has grade 1 DCO. And while here you have some marrow edema anteriorly and posteriorly, doesn't completely span the bone, and the superior aspect here is not involved. And there's no other findings, so grade 1 makes sense. I think DCO is not an uncommon cause of pain, should be looked for, especially in young men and women who lift weights, which means when we're reporting these scans, it would be nice if we have a history of weightlifting. So whoever takes history can be primed to ask for weightlifting, including bench pressing in young men and women, so that this can be correlated without saying, advised clinical correlation, etc. Now this is next Sunday. We have about 4-5 days in which you can try and register my WhatsApp channel. Thank you so much for viewing this.